Yes, sir. The session is now on YouTube, live streaming on Ortho TV, and we are very much thankful to the authorities of Ortho TV and especially Samsuluda sir, because from the beginning of this webinar session, Samsuluda sir give us this type of support every day in his busy schedule. We are really thankful to him. And Samsullah sir, we want to start now.
Yeah,
Yes, sir.
Yeah, you're gonna start now. I'm making you host. Okay.
Yes, sir. Yes, sir. With the permission of the Bari sir, we want to start the session.
Yes. What is
Yes,
the time
sir.
now?
Sir,
Okay,
it
8
is
minutes already. Start.
yes, sir.
Start. Modi.
Yes, start.
Are you start?
And yes, sir. You know that today is the lecture 21 session today, and today the session will be presented by Dr. Ghazi Hassanul Munir. He is recently working as a assistant professor and a very potent member of 7 Kurgan fellow, and his topics is rehabilitation after the ILIZAROV surgery. I request Ghazi Hassanul Munir, please share your screen, and so that we can go to the presentation, sir.
Today Nazmuluddin is Shetu is absent.
Shetu. Okay, we see your screen. Just go in the slideshow.
Okay.
I request everyone to mute your microphone so that noise is less.
Thank you, Dr. Arif, and thank you, Bari sir. Welcome to our Bangladesh Kurgan Fellow Group webinar session, lecture 21. I am Dr. Ghazi Hassanul Munir, delivering the lecture on rehabilitation after ILIZAROV surgery, learning to live with an ILIZAROV frame. What is rehabilitation? According to WHO, rehabilitation is a set of interventions needed when a person is experiencing or is likely to experience limitations in everyday functioning due to aging or a health conditions, including chronic disease or disorders, injuries or traumas. It is the act of restoring anything to its original state. What are the aims of rehabilitation? To enhance and restore functional ability and quality of life to people with physical disability and impairment, helping the patient to return to a healthy and active lifestyle. The stages of rehabilitation are reduction of pain and swelling, recovery of muscle strength, recovery of motion, that is restoration of joint mobility and range of motion, recovery of function. The types of rehabilitation. There are 4 types: medical rehabilitation, psychological rehabilitation, social rehabilitation, and of course, the vocational rehabilitation. Medical rehabilitation, to increase potential capabilities to restoration of functions and to do physical and mental activities. Psychological rehabilitation, to restore confidence and personal dignity. Social rehabilitation, to restore familial and social relationship. And vocational rehabilitation, to get employment. It is also very important. What are the benefits of rehabilitation? It can reduce the impact of a broad range of health conditions like injuries or trauma, disorders and diseases, helps to prevent complications associated with health conditions, helps to minimize or slow down the disabling effects, helps to avoid costly hospitalization, reduces the hospital length of stay. Rehabilitation is a teamwork which includes a physician, physiotherapist, rehabilitation nurse, and occupational therapist. Rehabilitation cannot be done with single physiotherapist or others. In muscle atrophy, the tissues in the muscles start to weaken and waste away. This can occur as a result of lack of muscle use, malnutrition, disease, or injuries. The muscle can be built back up with specific exercises combined with proper diet and lifestyle. Muscle atrophy. Muscle can atrophy from disease or when they are not used regularly at an appreciable level of exertion. This disease causes the muscle tissue to break down, shorten in length and waste away. You always think that muscle atrophy and muscle weakness, wasting is not the same. When a disease or injury make it difficult or impossible for you to move an arm or leg, the lack of mobility can result in muscle wasting. And when muscles waste away, caused by a lack of physical activity, that is muscle atrophy. Symptoms of muscle atrophy. Decrease in muscle size in one limb, muscle weakness, skin around the affected muscle seems to sag away from the muscle, a feeling of stiffness or heaviness in the affected limb, difficulty lifting things, moving the atrophied area, or during doing exercise that one was once easy, pain in the affected area, back pain, and difficulty in walking. Common muscles atrophied in the leg, the calf muscles, gastrocnemius, in the thigh, the quadriceps commonly, and also the abductors. And in arms, commonly biceps are atrophied. To regain from muscle atrophy, what to do? Patient should be advised to do physical exercise, get more protein and carbohydrate, vitamin D, electric myostimulation, and vibration therapy. A surgical intervention needs proper counseling, preoperative planning, selection of appropriate implant, operation, postoperative care, pain control, wound pain and frame care, physiotherapy, managing at home, and also the follow-up. Risk of surgery. There are so many risks. Anesthetic complications, there is infection, blood vessels problem, nerve problems, joint or muscle problems, wire or pin breakage, non-union. You already heard the lectures previously about their management. Most important factors affecting joint motion after ILIZAROV operations. In the postoperative phase, pin site pain, wire placement, and psychological status. Destruction phase, pin site pain, wire placement, condition of the soft tissue, and psychological status. And in the fixation phase, all the fours, including the constructive features. This is the reference from Timoseva Elena Kurgan. You are a good surgeon. You can do a very excellent operation. But if the patient can't move, the whole operation will go in vain. So after operation, you have to take more care about the patient. Patient may be reluctant, but ensure rehabilitation of the patient. So after operation, teach how to clean pin sites for the first few days with sterile swab. Teach patient or a nominated person how to care for pin sites when discharged home. Show how to shower with the frame. Keep the limb dry that has the ILIZAROV frame. Leave any crust that form around the pins. These crusts are a natural barrier from infection. During sitting or lying down, keep elevated the limb as it helps to reduce swelling. Describe to make a cover for ILIZAROV frame to prevent damage to other limbs, clothes, and bed linen from the exposed pins and hurt the partner. You have already learned about the pin site care by Dr. Hamidul Islam from his lecture. These are the dressings. And this is the Kurgan view. The rehabilitation nurse is in Kurgan in her dressing room. This is the role of physiotherapist. Teach exercises to keep joints moving. Teach exercises to strengthen the muscles of the affected limb. How to walk with crutches if required. Advise to use foot splint that helps to stress the Achilles tendon and prevents foot drop. Here, the expert physiotherapist in Kurgan, in our country, we have no such a physiotherapist. We have, but not like those. What are the roles of the physician? Explain how much weight can be put on the limb with ILIZAROV fixator. Tell when follow-up care is required. Discuss when the patient can return to work. Provide prescription, work certificates, or letters required on discharge home. But total work is under supervision of physician. Now, for compression and destruction, you must teach properly the patient how to rotate screw 6 hourly. You know, the spanner has the long axis, which with the slot, long axis of the slot and the long axis of the spanner has a 15-degree angle. You know it. And if you place spanner over the screw and just rotate the spanner, and then you will see there is a 90-degree angle like this. So teach your patient to hold one spanner and hold another spanner like this, then put the first spanner on the second and the second to the first. Then it will turn a 90-degree like this. You also can mark the screw with colors. What are the concepts of post-operative physiotherapy? Weight bearing is essential to maintain structure, shape, and volume of muscular system, to increase adequacy of blood supply, to increase adequacy of blood supply, tension stress as a factor for maintaining and stimulating tissue genesis. Possibilities with the ILIZAROV method to secure high functioning level throughout the entire treatment. ILIZAROV frame cover. It keeps the cold and heat of the frame and the pins, aids with protection of clothing and bed sheets, etc. Keep the dirt, dust, and pet hair of the pin side to help prevent pin site infections. And overall, it protects the partner from the pin injury. We can use tracksuits or jogging pants that have zips or poppers along the outside the leg as a ILIZAROV frame cover. Long skirts can be used, and two sides open cover like side pillow cover can be used as ILIZAROV frame cover. Like this, when there is the ILIZAROV ring in the upper limb, you can use the shorts like this, the zippers on the right side. When you use a ring on the leg, then zippers on the side, and in the thigh, zippers on the side, but extra cloth should be added. Here, ILIZAROV frame cover is on the leg, and here Professor Coulson is demonstrating ring and the frame cover. Now, what are the common exercises your patient can do to prevent atrophy? Tell your patient that it may feel uncomfortable at first, but these exercises will speed your recovery and actually diminish post-operative pain. The exercises are quadriceps strengthening exercise, knee strengthening exercise, abductor strengthening exercise, and upper limb exercises. In quadriceps strengthening exercises, the ankle pump, straight leg raise, knee strengthening exercise like sitting supported and unsupported knee bends, stair climbing and descending, standing knee bends, assisted knee bends, knee exercise with resistance, and exercycling. Abductor strengthening exercise, upper limb exercise like gentle pendular exercise, flexion and extension at the elbow, grip exercise, rotational movement, and others. Soon after surgery, patient is advised to walk short distances with a walker or crutches in hospital room and perform everyday activities. This early activity aids early recovery and helps knee and hip regain its movement and strength. Ankle palm, lock it, moving foot up and down rhythmically by contracting the calf muscle and shin muscle. Perform these exercises periodically for 2 or 3 minutes, 2 or 3 times in an hour. Straight leg raising. When you put a frame on the leg, tighten the thigh muscle with knee fully straightened on the bed. Lift leg several inches, hold for 10 seconds, slowly lower and repeat until your leg feel fatigue. Knee straightening exercise. Place a small roll towel just under the knee. Tighten your thigh and press knee over the towel. Try to fully straighten your knee and to touch the back of your knee to the bed. Hold fully straightened for 5 to 10 seconds. Repeat until your thigh feels fatigued. Sitting supported knee bends. Place foot behind the heel of your operated knee for support. Slowly bend the knee as far as can. Hold the knee in this position for 5 to 10 seconds. Repeat several times until leg feels fatigued or until knee bends completely. Sitting unsupported knee bends, bend knee as far as until foot rest on the floor and hold for 5 to 10 seconds. Now straighten knee fully. Repeat several times. Knee straightening exercises. Place a pillow over the leg. Straighten knee fully, very slowly, and hold for 5 to 10 seconds. And then bend knee as far as possible until foot rests on the floor. Repeat it several times until the leg feels fatigued. Abductor strengthening exercise. Lying over a bed or sitting on a chair, move the affected limb apart from your normal limb and then keep it close to your normal limb and do it repeatedly. Repeat several times. Assisted knee bend exercise. On sitting position, place a fold towel over the operated leg. Bend knee and apply gentle pressure through the towel to increase the bend. Hold for 5 to 10 seconds. Repeat several times until you feel fatigued. Climbing stairs. It is very much important in the modern life. While climbing up stairs, lead the good leg first. It needs handrail for balance and a crutch for support and will be able to go one step at a time. First, lead the bad one. Descending stairs. While descending down stairs, always lead operated limb. First, the operated limb, then the normal limb. It also needs handrail for balance and a crutch for support. You always remember, up with the good and bad, down with the bad, down with the bad, and up with the good. Biceps strengthening exercise. Hold your arm out of the palm of your opposite hand facing upwards. Bend your elbow and touch your fingers to the same shoulder. Then straighten your arm. Repeat this for several times. This is physiotherapy staircase in the Kurgan Physiotherapy School, where patient is taught how to climb and go downstairs. This is the trolley to carry patient with ILIZAROV ring. Look, there is a curtain at the trolley to keep the frame of the patient. This will comfort to the patient. These are the beds for the ILIZAROV patient. Multiple pieces of foams are adjusted to this bed and to give comfort during lying down to prevent sagging of the thigh. Look, The foam is here and here, but there is no foam to keep the frame inside. This is also the example. Look, the frames and the foams. Here, the foams are placed one after another to stand up these cute babies. And this, she is playing with her limb, keeping in the holes between the leg, between the bed. This is the Kurgan Physiotherapy School. You see, it is nicely arranged. This is the physiotherapist and with the fellows. These people are doing exercises there. In Kurgan Physiotherapy School, she's doing exercise with expert physiotherapist under control. This is also the view of the Kurgan Physiotherapy School. Always ask your patient to do exercise in supine and with prone position to prevent sagging. If you do exercise or lie down always in supine position, the frame must be sat down. So you do exercise in supine position and also in prone position. This is the example of rehabilitation. This baby is lying down and watching movies in the tab, and this is climbing in the bar attached with his bed. Here, appropriate foot splint is needed to walk. It is very much important. You see on her right leg there is a splint, frame is there, and as her left leg is short, there is foot splint to cover the height, and she is walking with her crutches. These are the recreational activity within the hospital. They used to perform in Kurgan Hospital to give recreation to the patients. You see, there is a patient on the trolley. Here, he has a ring in his head, and so many patients and their attendants are watching the program. Now, this is the case from done by me. This is the olecranon fracture, and it is done closely with frame. And after operation, he can do everything just after the operation. He can weight bear with his hand, and there is no problem. And after operation, no need to do anesthesia to remove this frame. And this is a case in the non-union tibia with implant failure, infected non-union. And after operation, he can walk, sorry. It was just before removal of the frame. Patient was operated, and after operation, he was advised to walk. Thank you. Thank you all. For live and previous session, you may visit ILIZAROV Clinic KOMC, Ortho World, Ortho TV Live. I invite you all for the next session, Biomechanics of ILIZAROV Surgery, on 22nd of this month, that is tomorrow, by our legend professor, M.M. Bari sir. Thank you all.
Thank you, Dr. Monir. Please stop your screen share so that we can go participation mode. And it was a excellent presentation indeed. So concise, so targeted, and so catchy, and especially the case sharing and all the Kurgan photos and videos that you have shared with us. Little bit time, just I feel that I go in the Kurgan center, just I am in Kurgan center. So thank you, Dr. Monir Hassan, for recalling that videos and that picture that we have taken with the permission of the Kurgan center and the permission of the patient. It was a excellent knowledge sharing presentation. Dr. Monir, you can get the screen share, stop screen share at the bottom of your screen or even the upside.
Oh, okay.
Okay. So I will go for the discussion session. Before going to discussion session, I request everyone, please send your question. You know, need to know many things regarding the rehabilitation, because just after operation, the main journey for rehabilitation began. And with this relation, I want to add few things with your presentation. As I told that your presentation was a brilliant and masterpiece and so catchy. In Kurgan Center, we found that they use the acrylic board or plastic board on the bed of the patient or physiotherapy bed, so that the ring moves easily when the patient abduct. When the patient have both limb ILIZAROV surgery, and he can easily moves adduction and abduction of the hip moving on the acrylic board. It makes it slippery so that the ILIZAROV ring cannot stuck in the bed. And these are the things, and you know that just after operation, the anti-gravity muscles are just begins to wasted more rapidly. So for better outcome, you have to do the physiotherapy. Now I want to go our mentor, Professor Mufakkar Bari, for your comments. And in between this time, I will organize the question answer session, and you please send me the question. And if any participant want to give the message or any question or any comments, please put your hands up. I will go to him. Mufakkar Bari sir, can you hear me, please?
Yes. You can hear me?
Yes, sir.
Okay. First of all, good afternoon, everyone. I must congratulate G.A. Munir for beautiful discussion showing everything. I have nothing to say, only I have a little bit observation. He rightly mentioned everything. The center, long before 70 beds rehabilitation center, now it is a cut short they have done for the beds problem. It is unbelievable rehabilitation center. I don't know whether you remember or not, when you were my student with me, I was always talking with you. All these videos, I have all these videos all the time. Just like, you know, catching everything, what you have shown. The rehabilitation, after putting the ILIZAROV, if you don't do anything with this rehabilitation, you don't get a good outcome result. You cannot expect that one. You rightly mentioned everything. And the case in the olecranon and the non-union, these are the beautifully you can tackle. And yesterday I told you, you can predict what is going to be happen. You can prevent that one, and tractable, PPT, preventable, predictable, preventable, and tractable. And you see the center when the boys or girls and the instructor, they're doing the exercise with a big glass so that they can see what they are doing. You have seen that one. Have fantastically arranged everything. And regarding the You have rightly mentioned post-operative period, and then distraction phase period, and the fixation phase period. They give emphasize all the time with the wire fixation, with the pin track infection, with the muscle activities, what you should have to do regarding the psychological aspects of the patient after the post-operative period, and at the same time in the distraction period, and at the same time in the fixation period. They give emphasize. These are the very important thing with the ILIZAROV fixation. No, you have rightly mentioned, I know this Timasheva Elena, fantastic lady. Even that day, she talked on 15th of June regarding the personalization of the physical activities in the Kurgan Center. That lady is working for a long time. I personally know this lady, Elena Timasheva. So principles of physiotherapy in the setting of transosseous osteosynthesis. You know what I have seen during my stay several times there. I have seen the British people, the Americans, the Koreans, the Japanese. They're coming just to learn what they're doing with the fixation of the ILIZAROV apparatus. Here, correlation of the physiotherapist with the transosseous osteosynthesis, number one. Number two, you should have to think about the personalization. Number three, structural and modification role of physical therapy. Controllable loading using the physical therapy, and anatomical and functional unity. Anatomical and functional unity of the frame and the patient. Frame and the patient. It's very important. So I must congratulate Munir. If you work with the physiotherapy, ILIZAROV frame, try to establish a center. I have my center with the rehabilitation. 2 physical instructor. I myself go there. I instruct them, you should do this, you should do this, you should do this. Applying the ILIZAROV apparatus, if you don't do any physiotherapy, that is rehabilitation, that is not the ILIZAROV surgery. That's why Professor ILIZAROV, I repeatedly say, he told all the time, and Shevtsov was all the first day I told you when I entered into his room, he was telling me, movement, 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 this is our task. And movement of the frame. I want to mention, I have noted down something for this. See, load and motion, what it gives, new things. When I will talk tomorrow, the biomechanics, I'll tell you the axial motion, micro motion, it is 1 millimeter in ILIZAROV, 1 millimeter. See, micro motion. Stability, stable fixation, even the AO groups, before they told about the rigidity, now they come to the stability, which was invented by ILIZAROV. ILIZAROV told the stability. And this ILIZAROV fixator gives stable fixation. See, I have written just after listening your this lecture, with the method of ILIZAROV, proton absorption, the value of the mineral on the fracture side was found to be 92 to 98% proton absorption. And in case treated by compression distraction apparatus, that is by ILIZAROV. And with the ILIZAROV ring fixator, compensation, or you can say complete mineralization, was achieved 12 days, only on 12 days mineralization. With other fixator, it took 150 days. So these are the all research work that are doing every day in Kurgan Center. You have seen, you have gone to the animal center. If you don't see, if nobody can see, they will not realize what is happening there. And this ILIZAROV apparatus, which is related to the fixator, total fixator, and at the same time, it is related to this compression and distraction apparatus. It is based on the Ohm's law. You know Ohm's law. Ohm's law, that means law of bone transformation. The shape and structure of the bone, is changed in accordance with the loading condition. This loading condition is rehabilitation. It's very important in ILIZAROV surgery. Very, very important. Why this rehabilitation is very important? Because this fixator serves 4 purposes. Number 1, you are giving stability. Number 2, when you are giving stability and loading, compression or distraction, you are getting billions of cells around the line of compression or distraction. This is established. And you are increasing circulation, that I am telling you all the time, 330%. This is also scientifically proved. And you are not disturbing anything there. And rightly, they are doing 3 phases always. And psychological effect of the patient during post-operative, distraction phase, and fixation phase. You must tell the patient. So thank you very much, Munir. Nicely. I am so happy that you have elaborately everything told, and so that I was just, Arif was telling that I am also just of yours. I have all these videos, put my own, everything that we have done there. So thank you very much. This is the learning, teaching for all, everybody. And once in a life, I tell all the time, those are the orthopedic surgeons, if you have time, you go and see. If you don't do ILIZAROV, that is the center in the world, only one center where research work is going on. Nowhere in the world, I'm telling you, nowhere in the world. On the basis of all animals, birds, dogs, horses, then this is called khorgosh, kralik, and all kinds of animals, they are doing research work. And then on the basis of that, they apply this in the human body. That was done by Professor ILIZAROV, and his all successors are doing this. So rehabilitation is very important. Try to, you, those who are the ILIZAROV surgeon, you please try to establish a small level, you do it. Then it will be helpful for you, for your patient, and you will get good satisfaction with this. These are the all sequential things. You applied, so finish, you go. No, this is not the ILIZAROV. All the time, you should have to love the frame just like your wife, I tell you. And ILIZAROV frame just like aeroplane. Aeroplane, stable fixation. Okay, thank you very much.
Thank you, sir, for your nice word and inspiring word every time. And I just want to share one of my experience in Kurgan Center. That Kurgan Center is a so big center, and the so many ILIZAROV patient. If you look in the garden, you can see that 2 or 3 patients are just in the garden roaming around with the ILIZAROV ring. If you are in cafeteria, you can see that patient with ILIZAROV ring with taking the dinner or lunch. If you go to the stair, that ILIZAROV patient is down, coming down or going upward. Even in the accelerator, everywhere. The so much ILIZAROV patient, so many ILIZAROV patient, I think you cannot get in any part of the world. And they are doing their activity very nicely and very easily. There are no hardship, no sign of pain in their face. And they are climbing upward, and they are walking, they are making jokes with each other. These are the things you can enjoy in Kurgan Center. Yes. As our program is just progressing, at the end of the program, we are getting more emotional as seeing the Kurgan pictures. As last year, more or less the same time, we are in the Kurgan Center. And for your information, you know that we want to share all our Kurgan photos, the selected and best photos with you in Kurgan diaries. That will be in the last presentation day. And I think you should always with us, and you can get the charm of Kurgan, with its food, with its natural beauty, with its peoples, and with all the things. You can get some idea about how the Kurgan territory of Russia is. So let's go to the most formal part. Some question is already comes to me, and I am going to Golam Farooq sir. Please have your comments, and if you have anything to ask GM Munir, you can do. Golam Farooq sir.
Hello,
Yes, sir. Can hear you.
Dr. Monir.
Thank you, sir.
It is a very much excellent presentation like previous one. I appreciate you and congratulate you. We know that rehabilitation is a part of treatment, either in trauma, in cardiac patient, or in neurological patient. Our parent organization did an RISD or NITOR. There is rehabilitation is the term is applied there in their name. But unfortunately, when I was in the NITOR in ILIZAROV clinic, we cannot develop any physiotherapist or involve any physiotherapy to us. This is the time have coming. We have to train up some physiotherapists with us to perform these duties and all the things we cannot do in a single hand. So we need some dedicated physiotherapists with us. I suppose you can organize in Kustia Medical College or NITOR and you are in life. No, thank you, Monir, for your brilliant presentation. Okay.
Thank you, sir, for your time-trusted and very important opinion regarding the physiotherapy session in ILIZAROV and other specialty of the orthopedics. And in this relation, I want to add my little information to you that with Samsul Huda sir the channel, the Ortho World, I got a webinar for a couple of days before about the role of physiotherapy in limb lengthening. I think you do not get this type of presentation because the physiotherapy especially oriented for limb lengthening, it was presented by Anil Bhabe sir from Baltimore, and he worked with the ILIZAROV for a few days, also with the Dor Pele and also with the Heisenberg and now, and it was a very good presentation on physiotherapy in limb lengthening patient. So for additional information and additional knowledge gathering, you can go through that video. It is in Ortho World YouTube channel. Just for your information, you can get some basic and also very important knowledges about the physiotherapy. And now I am going to the question answer session. There is a question from presenter, from the presenter to everyone and especially to Bari sir. Which muscle was in the forearm after the ILIZAROV fixation? It is question from G.A. Muni to Professor Bari sir. Bari sir, you got the question, sir?
Which muscle is atrophied after the application of ILIZAROV? In the forearm.
Forearm.
In
Yes,
the forearm.
Forearm, yes, sir.
In the forearm. If you injure the nerve or if a nearby nerve, anywhere it can be happen. But I am in my life, I have not seen that one. This is the answer.
Thank you, sir.
Especially in forearm, when you place the wires, you should always be meticulous about the length of the flexor tendon and extensor tendon, and also respect the joint positioning of finger joints and also the wrist joint during the insertion of the wires. If you just respect this, you can spare all the tendons around the forearm, so you can get the good result and also the full forearm and hand function afterwards. So now I am going to another question to Dr. Munir Hussain. G.A. Munir. And you know that G.A. Munir have a very similarity with G.A. ILIZAROV. G.A. ILIZAROV and G.A. Munir. I think
Gabriel Abramovich Munir.
and every time in our forum, we used to just make fun with Dr. Munir, very much respected to us. But you used to, you are very much similar with ILIZAROV, and also he get very much shy for this. And now the question to question to Munir, to Dr. from Hamidul Islam: how long should we continue physiotherapy after the removal of the frame? Munir, can you get the question?
Yes, thank you,
Yes.
Dr. Hamid. You can continue physiotherapy up to the patient gain his full muscle contraction, full mobility, then you discard your physiotherapy program. Just after gaining the mobility and joint functions, you don't have to keep continue the physiotherapy. Okay.
Thank you. Hamidul Islam, I think you got your answer. I request all the co-hosts of this session, Abdullah, Mustafa, and Nazmul Shetu, please, you will be connected a short time later. And if you have any question, you can add. And now I have a question to Dr. Mufakal Bari sir. Sir, whenever we do the ILIZAROV surgery around the femur, sometimes many of our ILIZAROV patient complain about the knee stiffness. And I think in femur ILIZAROV, knee stiffness is a very problematic one. Sometimes we need to do the Jodist cordyceplasty. Please, can you make some comments and advice regarding how we can prevent this type of knee stiffness in femur ILIZAROV? And is this the stiffness is a most evitable thing after the frame when the frame in ILIZAROV in femur?
When stiffness occurs, number one, the patient late case or 2 or 3 times intervention was done in the lower end of the femur or middle of the femur.
Yes, sir.
If you do it because already adhesions, lot of adhesions there, 1 time, 2 times, 3 times intervention was done, there is a lot of adhesions, lot of fibrous tissue. That patient has come to you, you have done the ILIZAROV fixator. And to apply the ILIZAROV fixator in the femur, you should have to go for bending of the knee. You must apply the traction. And most of the orthopedic surgeons, even the ILIZAROV surgeons, they don't follow this rule. If you don't do that, then you are inviting more stiffness. This is number one. And if you go for lengthening beyond more than 4 or 5 centimeter, you must laterally resect the TFL, tensor fascia lata, lateral side. If you don't do that, you are getting more stiffness. More than 4 to 5 centimeter, if you go for lengthening in the femur, you must cut the tensor fascia lata laterally. Then you can prevent that one. And otherwise, ILIZAROV, if you put in the lower end of the femur and at the same time in the upper of the tibia, near that is juxtaarticular, you will get all the time stiffness. So after removal of these, I don't know whether you have seen in Kurgan Center, they have underwater massage therapy. Have you seen that one?
Sir, we heard about that, but we don't get the
underwater massage therapy, paraffin therapy, they are utilizing that one, and always vigorous physiotherapy. So my suggestion is that you must maintain the rule when you are fixing the ILIZAROV apparatus in the femur, try to apply traction in the tibia, upper tibia, with bending condition. If you do it straight, and you should have to maintain how you are putting the wires from front side, back side, or lateral side. These are the very important things. And try to avoid the muscles or tendons when you are putting the wires. So this is one thing. Another thing is 4 to 5 centimeters beyond, you go for fascia lata cut. And application of ILIZAROV in the femur, you must have very much cautious. And most of the orthopedic surgeons, not ILIZAROV surgeons, they are vaguely all the time taking cumbersome in the femur. I am not agree with them. Cumbersome for that person who is taking without knowing anything about the ILIZAROV. You have seen in the ILIZAROV center how they have applied ILIZAROV. Patients, adult or children, they are very easily. Children, ILIZAROV, fantastically, they are with ILIZAROV.
I think Bari sir.
Meticulously, you do, let's go. See, the polychronon, which way Munir did, I am very much, glad that this is the beauty of ILIZAROV he has done. Fantastic. See, get a rehabilitation, they did. But the man, those who are not, knows the mechanism, biomechanics, everything of ILIZAROV, this. Don't believe. That's why I'm telling you, don't listen to the living failures. You know living failures, how you can clarify living failures. A lot of people, they can die. Whenever you do ILIZAROV, just put the whole center in your mind. Then you will be able to do everything. Fantastically, he has done this one. I must appreciate. It's good. Good. Patient can do everything. No plaster, nothing. This is his job. Okay.
Sir, I have a complimentary question to you. Sir, for information to everyone, what is the ideal position of knee when you do the ILIZAROV surgery in the femur?
If you do it more than 90, a little bit, 110 is good. This position. Can you see this one?
Yes, sir. You can see this, sir.
No, this one. See. 10, 15 kg weight with K-wire and then half ring. You apply tension with K-wire, put 1.8 in the tibia, half ring applied, you have a dynamometer tension, then you just apply the weight. And then you go for application of the ILIZAROV in the femur. If you don't do that, you will face problem. Big problem.
Thank you, sir. The lesson from this statement is that during doing the ILIZAROV surgery, please don't use the as usual CM fracture table orientation, because in fracture table orientation, the CM usually you can put the limb in full extension and sometimes the more extension. So at the time in extension, every extensor and the quadriceps get the shortest of his length. So the chance of the wasting is more when the length of a extensor muscle, especially the quadriceps length, is becoming short at the time of operation. And
then,
yes,
yes.
Sir?
One thing, you have seen in your life the rupture of the quadriceps. Codivilla operation. Do you remember that one?
Yes, sir. You can remember, sir.
You have remembered. But I have done this operation to Shaikh Shira's elder brother. After suturing, apply the ILIZAROV. Apply the everywhere you can apply ILIZAROV. After suturing, because this one. Even if you go for habitual dislocation of the patella or recurrent dislocation of the patella, I don't know whether you have seen in the Kurgan center or not. After reconstruction, whatever may be the you go Krogius method, Campbell method, House's method, apply the ILIZAROV. After 1 or 2 days, you are getting the stability and exercise.
Thank you, sir. This is a message to everyone.
These are all message. Rehab.
Yes, sir. Not only the bones surgery required ILIZAROV surgery, ILIZAROV technique, but also for soft tissue protection. Even you can protect the skin graft in your limbs, even any problems in the calcaneum. Even you can protect your flap surgery by simply putting 2 wires above and 2 wires below and with a ring. And in this manner, you can protect your limb in 360 degree. There is no need of any plaster, no need of any.
Yes, that statue, dead statue, not living statue. Living since 1992, telling ILIZAROV's law. That statue, whenever you enter, written statue, ILIZAROV's law. What is that law? A law gives everything. Keep it in your mind, always here. Law of tension and stress. ILIZAROV's law. What is ILIZAROV's law? Slower and steady. Keep it in the lips, in your lips. Slow and steady traction on a living tissue creates a stress which is metabolically activated and which stimulates histoneogenesis, dermatogenesis, neurogenesis, angiogenesis, tissue genesis. What you did? Nothing. This is ILIZAROV, and you can do with these waves.
Thank you, sir. Everybody should follow these principles.
Now you'll do. I have done a lot of cases in my life, and I have got the documentation. And you must do that. You must have documentation. What? Munir, Hamid, and Nazulullah Shetu, Arif, you have all this. Abdullah, everybody, please keep and proceed.
Thank you, sir. And there is another question, sir. It is open to the speaker and as well as to you, sir. What is the difference between the lengthening and transport rehabilitation? And
very simple, very simple answer.
Yes,
you answer this. Transportation and lengthening, this is very simple answer. You answer this. You don't know
Yes,
that, I will
sir.
tell. Hamid,
Yes,
Hamid, he knows very well. Munir knows very well. You know very well.
Yes, sir. I am going to Hamidul Islam. What is the difference of stiffness in transport and and lengthening? What are the chances and what are the problems? Hamidul Islam, sir. Hamidul Islam, sir. Unmute yourself and you can add your comments. Hamidul Islam, sir. Unmute yourself.
Probably we learn from our sir.
Yes, sir. Munir, do you want to add, sir?
Probably we learn from our sir.
Okay, I go to Bari, sir. Before that, I want to go to Nazmuluddin Shetu, sir. Nazmuluddin Shetu, sir.
I am looking. Abdullah is raising hand. He is willing to answer the question, probably. Abdullah.
Abdullah, sir.
All of us agree to hear this answer from you, sir.
Arif, you tell.
Yes, sir.
Or Shedu, ask Shedu.
Okay, sir. Thank you, sir.
Very simple.
Begin with the permission. You think that you are doing the lengthening and you are doing the bone transport for bone gap. Just everything you should be individualized as particular case oriented, particular case basis. That in bone transport, if here is a gap with no LLD, what you are usually doing, you are doing the bone transport and the filling the gap. But here you are not changing the length of the limb. But in case of lengthening, when there is the short stature lengthening or other form of lengthening, you are doing the change. You are changing the length of the limb. When they are changing the length of the limb, then all the muscle, fascia, tendon, nerves, and every structure have a resistance for not doing this type of lengthening. And there is that distraction resisting force acting all over the frame and also in the limb in case of lengthening issue. For lengthening, the chances of joint stiffness and joint fixation or subluxation, this type of things happens very frequently, and you should keep it all in mind. And sometimes when you lengthen the tibia, you may need to look very meticulously to the ankle joint, also the knee joint, because that can be subluxated, can be get fixed in equinus position or even knee in the flexion position. So lengthening, always you are very much careful about this type of stiffness. But in transport, usually you are in the more or less safe position. If you continue good physiotherapy, then this type of severe complications usually do not occur when you transport any segment of the bones to fill up the gaps. And there are some certain limits. There are a normal protocol in everywhere in the world. If you increase a limb more than 5 centimeter in length, then there must be some complications in joints or any soft tissues. And even there are some part distribution. If you increase the proximal tibia, there are chance of chance of ankle equinus formation is less than if you increase the length in the distal tibia, the chance of equinus stiffness is more. So,
listen.
Yes, sir. If you want to, yes,
sir. Regarding the superior extremity, if you go more than 20% of your extremity, it doesn't disturb. Inferior extremity, if you go for more than 20% of your superior inferior height, 20%, it will create problem. So you can, here more than 20% you can do, but here in the inferior extremity, if you beyond 20% of your height in the lower extremity, it will create problem. So even then, you should have to go for that. Then regarding the transportation, you rightly answered, gap fill up. Sometimes transportation with shortening. Sometimes you will get transportation gap with shortening. Then you should have to go both sides, lengthening and at the same time fill up the gaps. Sometimes you'll get only lengthening, this is cosmetic lengthening or achondroplastic lengthening, that is quite different. But both way you should have to lengthen. This is the difference, nothing else. Okay.
Yes,
And and doing ILIZAROV, you must be always your brain with work. Your brain will work very nicely if you meticulously follow the ILIZAROV everything. This is a mathematical calculation. Always you should have to calculate. Physics. Those who know the physics and mathematics a little bit better, they are the good ILIZAROV surgeon. This is the, you see, Professor ILIZAROV is a self-taught orthopedic surgeon. This is God-gifted. You must realize that. So these are the all things, lot of tidbits, lot of problems. Even then, most stable, most authentic fixation in the world. Okay, thank you. Proceed.
Thank you, sir. There are another question. The question is, where the chance of stiffness is more, the early part of distraction or late part of distraction? To Munir, where the chance of joint stiffness is more, at the early phase of distraction or late phase of distraction? Munir, please unmute yourself. And Munir, sir.
Yeah,
yes,
please.
So there is a question from the participant. Where the chance of stiffness or joint contact is more, in the early phase of distraction or the late phase of distraction?
So far I know that the chance of contracture is developed in the early phase, but I want to know the details from Bari sir.
Anybody wants to add?
Yes, sir. I mean, I want to add with Dr.
Please.
Usually, I am just with respect to your opinion, I am just a little bit the opposite direction of your answer. Usually, the contracture usually developed at the later part of the distraction, because in the early part of distraction, the tissue redundancy or elasticity sometimes copes some amount of distraction resistant force. But at the later part of distraction, if you distract, like the example in the tibia lengthening, the equinox contracture development or knee dislocation usually appear at the later part of the or the last phase of the distraction. And
distraction phase is last. Yes, it starts initially, but you will get it contracture in the later stage. Distraction phase, later stage, you will get it. Okay.
So this is a message to all. Usually you have to more careful for following the patient at the later part of the distraction. If you want to just equalize the limb length like the like 3 centimeter or 4 centimeter, just the last part, last 10 days or last 15 days is more crucial. In this time, you have to follow the meticulously with this patient. And there, with the reference of Ghulam Farooq sir, sir told us that there are very much problem in physiotherapy, especially in Bangladesh. I think many part of the world, the scenario is the same. So we have to think more differently. How can we get connected more and more with our patient with ILIZAROV? Even in this COVID situation, many of our patient is out of reach for the last 3 or 4 months. So it is high time to think if a patient get disconnected or any reason, the patient cannot come to you, how can we help the patient? And I got an idea just a couple of days that every time when the patient come to your chamber or your ILIZAROV clinic, you have to show the patient the actual way of how to get the physiotherapy or how to get the mobilization of the joint and you have to just take the video of that point of time of with the patient and your demonstration, and ask the patient to just follow this movement repeatedly when you go to your home setting. Sometimes this type of video demonstration of one patient itself with the treating physician helps a lot, because the patient may not come every day or every week or any interval of time, but this type of patient oriented physiotherapy protocol with video demonstration helps a lot for minimizing this type of problems. So now I am going to Nazmullah Shetu sir. Sir, we cannot hear you from for a long time. If you want to add anything, please add. Nazmullah Shetu sir. Nazmullah Shetu sir, I think he is okay. Now the everyday, if we don't have any question, then we can go sequentially from the co-host, then Bari sir, and then to the Samsulu.
Raising hand.
Arif,
Yes, sir. Oh, okay, sir.
if you, do you want to say anything about you are calling me?
Sir, I'm calling you because
You're sleeping, eh?
No, sir. I'm just out of it here for few minutes.
Sir, we want to see you, sir.
Oh, my network is very weak. I'm trying.
Okay, sir. Okay, sir. I think you have you heard the listen all.
I have already learned the whole session, and I was in nostalgic about the in presentation of Dr. Munir. He brilliantly presented the topics, and also I'm in nostalgia when we are enjoying the time in Kurgan in 2019. That was a beautiful time, and we learned from there very many things. But by this time we lost the we have out of the memory, and we Dr. Munir, thank you Munir to recall all things, and very nicely demonstrated all the things, and I heard all things, but I'm not well connected due to network disturbance. Sorry. Thank you, Arif.
Thank you, sir. And in this relation, I want to say one thing is that sometimes the patient-to-patient motivation is very much important or very much helpful when a patient sees that his same patient with same problems just doing his physiotherapy and everything very well, then the patient get motivated, and patient got the encourage for doing the physiotherapy or taking the steps in moving himself. And also I want to refer one part of the presentation of Dr. G.A. Munir that Barisar used to tell us every time, you think your patient as a whole, not as a problem with his limbs, with ILIZAROV, not like that. You think about the social status of the patient. You think about how the income generating of the patient is going on, how socially he is rehabilitated, how much time he spent outside of his home, and how much time he spent just thinking himself in lonely in the house. And these all the things have very much impact on the overall recovery. You have to motivate your patient to speak up, to meet the other people of his community, and also with the other patient with the same problems. Then many times the patient can manage himself to organize many of his problems. So I think everyone have a good mind, and everyone have a new thinking and new innovations for doing this type of things. And now I am going to Ghulam Mustafa sir. If you can.
Dr. Arif. Dr. Arif.
Yes, sir. Sorry, sir.
Just I want another thing.
Yes, sir.
Patient motivation for the ILIZAROV surgery. One thing that is just look like a biocenter. There is our search center. When a patient come to the center, you can see there are a lot of patients with ILIZAROV. Then he is automatically motivated and boost up to do the ILIZAROV surgery. He needs less motivation. So it is a good thing that when your chamber or your center will fill up with a lot of patients with ILIZAROV, then a new patient needs a simple motivation to do this method. Then after the operation, when you send this patient to the physiotherapy center, then he saw that a lot of patients are doing the physiotherapy. So his mind is already set up to do this. And it is a good way to do the physiotherapy for the patient, I think.
Yes, sir. Just the thing.
Can I add regarding this, what
Yes, sir.
Nazmullah Dashitu told? This
Yes,
is for everyone, not for me also, for everyone. Initially, you will face a lot of problem. Initially.
Yes, sir.
Don't think about that all the time everything will be okay. If you are sincere, if you have a devotion, if you have a dedication, if you believe in Allah, and if you have righteousness, inshallah you will proceed. So what I do, you believe it or not, before Corona, early in the morning after the Fajr prayer, 6:30, I was walking outside and with this tracksuit. Before that, they know, my brother and doctor, they know that I will come. And in the male ward, I enter into the male ward. Male ward in general, all beds are orthopedic beds, ILIZAROV beds, rather I should say, ILIZAROV beds. And I start myself doing exercises with all the patients. 15 male in the same room. I start myself 6:30 in the morning. Then every patient, they know, the brother and sister and doctor, they know that I'm coming, and they get ready before that. And I do the exercises. And one thing at that, if you can put in your chamber, whenever you have a personal chamber, you can put something in your video, in a TV. And during my consultation time, everything is stopped. There are a lot of videos with ILIZAROV, and everything is just there. And they are looking, the patients attendants, they are observing what is happening. And they psychologically, they, a little bit build up what is going here. And they know all the pictures. You should have to show all these pictures, everything in your chamber. Beautifully decorated you do, and some flowers, and your surroundings, those working with you, they must have good behavior. Good behavior. And doctors' behavior is good. Behavior is not good, patient will run away. So that's why these are some things you can put in the TV. This is you have done 3 or 4 cases or 20 cases or 100 cases. You cannot show everything, little you show. And you establish, those who are the ILIZAROV surgeon, please establish, try to a little bit your physiotherapy center in your place. Or if you don't afford that one, you only establish with yourself, with the patient, you must do it. These are the things you should do. And always frame, tell the patient, love the frame just like your wife. Do you love your wife? Yes, I love my wife. Then if you love your wife, you should love this one. Otherwise, you will not get good result. You must talk with the patient like that. Okay, thank you very much.
Thank you, sir.
Sir, in the Corona period. Sir, in the Corona period.
This is not, I'm not talking after Corona.
Thank you, sir, for a nice comment.
During this Corona period, we are quarreling in the house.
I want to add 2 of my experience with you, and also one of our activity in Kustia Medical College ILIZAROV Clinic. Some of our patient is so motivated, and one of my patient just donate a LED TV for ILIZAROV Clinic in Kustia Medical College.
Very good.
And I put all the exercise videos, even some of the videos from the YouTube and also from the Kurgan Center and my patient video in that TV. And every time when the patient just start our clinic, this type of video demonstration all the time, repeating for 1 or 2 hours before we start our session usually in 12 p.m. every day, every Wednesday. So this is a good learning for everyone, that you can motivate your patient in this like way. And now with the permission of sir, I want to just share one of my residency sweet memory with professor. To be a good surgeon is not enough for doing ILIZAROV. You have to be a very good man. When I was a resident in a Barisar unit, one day we went for a round in the ward, usually in the GI's ward, it is a female ward, and some of our patient, ILIZAROV patient, the sweet patient is about the 10 years. He is just dressing his hair with the comb. And Barisar just took his comb from that patient and just started to dress his hair very nicely and take a very good picture. And at that time, I was get so inspired that a doctor should have very intimate relationship with the ILIZAROV patient, so that you can be a friend to your patient and also realize all the sufferings of the patient. Then you can do a better work for the ILIZAROV technology. So this is one of my perception, one of my feelings I got from Barisar, that he is so much intimated to the patient every time. And now I am going to ASM Abdullah for your comments, and also if you have any question to the speaker.
Dr. Ken is here.
Yes, sir. Ken sir, how are you, sir? Abdullah sir, do you want to add something, or it is a ending commentary from you?
Thank you. Thank you, Dr. Arif.
Yes,
thank you, our Dr. Gabriel Abramovich or Munir Bhai for her nice presentation regarding the rehabilitation. Actually, in ILIZAROV surgery, postoperative rehabilitation protocol is mandatory for all patients. In our Kurgan life, we have seen all good rehabilitation protocol in Kurgan Center. So we should follow that. Many thanks and much gratefulness to our mentor, legend ILIZAROV surgeon, Professor M.M. Barisar. Especially thanks Dr. Samsul Huda for his nice cooperation. Thank you. Thank you to all for nice patience hearing. Thank you.
Thank you, sir. Now I'm going to Ghulam Mustafa sir for your short comments, and if you have any question. Ghulam Mustafa sir, can you hear me, sir?
Can you hear me, sir?
Yes, sir. I can hear you, sir.
Assalamu alaikum.
Yes, sir.
First of all, I want to say that the lecture of the GM Munir sir is very nice. He nicely and elaborately mentioned everything, and especially the discussion. Every day we are learning much more things, and I am always grateful to my mentor, Professor M.M. Barisar. If he is the inspiration of me, and I am what I am today is behind the man is he.
Oh.
And I think it is high time for the ILIZAROV surgeons who are practicing in our country think about the rehabilitation of the patient, especially set up physiotherapy center or physiotherapist at least in our daily practice, so that the outcome of our ILIZAROV become very good. And thank you to all.
Thank you, sir. Sir, in this relation, I want to add information for everyone. Mustafa has a complete package in his family. Mustafa is an orthopedic surgeon. Mustafa's wife is an anesthetist, and Mustafa's younger sister is the physiotherapist. So,
then they can run a very good ILIZAROV center.
Yes, sir. And Mustafa got the complete package in his family. So I think he can go ahead for the ILIZAROV technique for more faster than us. And now I am going to Barisar for concluding comments. And
Ken and Adekunle, they are raising hand. You have not seen.
Adikunle sir, please.
Yeah,
Yes, sir.
thank you very much. I want to thank the presenter for a very good job, Dr. G.A. Munel. That's a very good one. If you have done a very beautiful job, you prevented injury to vessels and nerves. And at the end of the day, the patient is not satisfied. No good rehabilitation, work done is zero. So this is a very good presentation. So I must comment, this is a very good thing. But I have one question, you know, if you are in a part, if you are from this part of the world, yes, where you don't have luxury of everything. When Professor Barry was presenting his case, he showed us the bed in his hospital. And then during this rehabilitation again, the bed was also emphasized. Now, my question is, for you to get the government to get these beds for you, it might be difficult. Are there ways of which you can improvise?
Thank you, sir. This type of bed in our local setting, usually where there is no type of such type of manufacturer with they can make the mattress like that. Usually, we in the local setting just customized our protocol. Everybody in Bangladesh in rural setting, they make the mattress out of the cotton and the fibers from the coconut integrated with the cloth, and you can make a part or cut a part of the mattress, and you can make this type of assembly with this type of things. And sometimes some parts of the world, even in Bangladesh, there are some manufacturer, they can build this type of mattress if you just told them and make the measurement, and you can have this type of assembly very easily if you have the mattress manufacturer in your country. If Bari sir want to add how you can make this type of bed, you can please add, Bari sir, and also your comments about session, sir.
Adikunle,
Sir,
Bangladesh is a country, you can get everything here. Even the eye of the tiger within 30 minutes if you have money. Very good country. Yes, yes, very good country. And I told the Nigerian fellows, Obinna, Emba, then Wahab Yunusa, and Ichi Oduko, he died. I told this fellow, I have shown them everything. You can talk with Obinna. He has taken a lot of picture for my hospital, and he will teach you how to make this one. Very simple. If I tell you just now, you will not be able to understand. Better you talk with Obinna, or you email me. I will send you what to do and how to do. Okay? You email me. I have the email. You email me. Thank you very much.
All right.
Dr. Arif,
Yes, sir.
Dr. Arif, I want to add some my opinion.
Yes, sir.
Sometimes I advise the patient, for the ILIZAROV patient, they can use the sofa foam that was used in sofa set.
Yes,
in
sir.
your set, there is a block type sofa that you can take the 6 set and you make it a bed, and that part you remove. ILIZAROV part, where the ILIZAROV was lies, that part of the set you can remove. So you can temporarily use it, and after the completion of the treatment, you can use the sofa set as usual. So you need no make any another bed or like that. So
Yes,
you
sir.
can use it temporarily.
Yes, sir. The lesson is that you can customize your necessity by what are the available things all around you, and usually so far I know that the condensed mattress materials usually available most of the part of the world. So you can make this type of with this condensed mattress particles. And I think if you need more assistance, you can contact with us with Bari sir and the Kurgan fellow in WhatsApp. Then we can send you the other details. How can we make the mattress for the femur patient? Now I am going to Bari sir for your concluding comments. And after that, Samsulda sir, if you are in online, please unmute yourself and we are coming to you. Bari sir.
So, good afternoon, everyone. My all national and international friends. Thank you very, very much. First of all, I should congratulate Munir again for beautiful presentation, showing everything. And we have learned a lot of things. I have learned a lot of things. That is repeatedly learning. So everybody is here, and probably rehabilitation is very important in case of ILIZAROV surgery. So I think you have learned a lot of things from today's discussion. Our discussion interaction was very good, and I am happy. And hopefully, very important is the biomechanics. And tomorrow, I'm going to talk on biomechanics of the ILIZAROV fixator. And this is very important, it's very difficult. When I was in the NITOR, I put some question to the residents. One day I put one question, please write down the biomechanics of the hip. The one of the resident, he has written like this: sir, biomechanics of the hip joint is so difficult, I cannot make you understand. So tomorrow I'll talk this biomechanics of the ILIZAROV. If you understand the biomechanics, then you will be able to proceed something with this ILIZAROV apparatus. Thank you, Shamsuluddin. Thank you very much. Thank you, everyone. Okay, bye.
Thank you, sir. And tomorrow, you already got the information, our presentation on biomechanics by our professor. So everybody should be connected tomorrow, same password ID. And now I'm going to Samsuludda sir for overall comments, and I am also delivering the host status to you.
Thank you, Dr. Arif. Thank you, Bari sir. It was a wonderful webinar on rehab after ILIZAROV. As you all know, rehabilitation and physiotherapy is a very important part, very important part after every orthopedic surgery, especially in ILIZAROV, provide stiffness and weakness. As Dr. Arif also mentioned, you can see a webinar by Dr. Anil Bhave of Baltimore on my YouTube channel. When I went to Baltimore, I met him. He's a very good physiotherapy and gait lab. He gave a very good description of the braces and all that. Thank you with this. Thank you, everybody. I'm concluding the session here and stopping live session. Thank you, sir.
Thank you, sir. Please stay with us on tomorrow, our professor session on biomechanics of ILIZAROV. And every time the biomechanics seems to be very difficult to hear. But I think after the session of Bari sir, you will get the good knowledge and also new encourage to work for ILIZAROV technology. And till tomorrow, I am saying goodbye. Assalamu alaikum. I am ending the session.
Bye.
Hope to see you tomorrow.
Okay, sir.
Allah Hafiz.
Okay, sir.
Assalamu alaikum.
Samsuludda sir, you need to send me